right, this is the Introduction to Dental Materials and Material Science. This is the PowerPoint that we started in class, and per request, I said that I would do a video going over the slides that we didn't get to in class and giving a little more explanation, slower, with my notes out all around me so you guys get all the information. Now, as dental hygienists, we need to study dental materials so that we know how the materials behave, so that we can properly handle the materials, we can treat the patient when they have different materials in the mouth, and we can educate the patient on different materials that might be used, the breakdown of different materials, why one is better than the other. We need to know the behavior of the materials so that when we're placing sealants, we're placing them properly. We have the right etchant going across the surface to improve wettability. We might be participating in maintenance of restorations. Maintenance is spelled wrong there, sorry guys. Maintenance of restoration, so doing some polishing of restorations, and we need to take care of the different instruments that we're using so that we don't have any corrosion happening. We have to handle the materials correctly because we have biomaterials that are, or synthetic materials that are going to replace things that are in our mouth, and they have to function and be in contact with the tissue and function properly in the mouth. Improper handling will affect some of the properties of those materials, and it could affect the overall service of whatever the restoration is, whether it's a denture, partial, bridge, or even a filling. It could affect that restoration and longevity. We need to recognize the different kinds of restorations clinically in the mouth and on radiographs. Sometimes you can't see an all ceramic crown in the mouth. They're really darn good. So if you were unable to recognize it in the mouth, you would certainly use the x-rays for assessing that patient. And if you saw a composite filling or if you saw a ceramic crown, there's different materials that you may or may not use. We need to be able to educate the patients about the materials that are being used on them. They need to know how to properly maintain the materials. So for example, a mouth guard or other appliance, we're going to want to tell them how to clean that. So cleaning it with, antibacterial soap and water in cool water. We don't want them to store it in a hot car. We don't want them to use hot water, put it in a dishwasher, anything like that. Patients might ask our opinion between different treatment options, and we have more credibility if we can explain those different treatment options. They might ask us about procedures related to the use of materials, what is in something. Like they might want to know if there is something in the plastic or if there's mercury in the amalgam, that kind of thing. So the more we know about these materials, the more we can talk to our patients and educate our patients about what is best for them in regards to restorative work. We talked about this question and reasons for RDH to understand materials, which are choosing preventative materials, cleaning instruments, and giving patient education. We don't need to necessarily know about inventory and cost choices. That's not the top priority when we're thinking about dental materials for the hygienist. So the oral cavity is a harsh environment when we've got that demineralization, remineralization process constantly happening every time you eat or drink. We have to replace any lost tissue, which is really lost teeth, or tooth material with material that mimics the function that was originally happening. We've got biting forces, we've got corrosion that's happening, we've got temperature changes, so we've got some expansion with heat, we've got some contraction with cold, we've got material within a tooth that is contracting and expanding based on the hot versus cold environment, or that's introduced to that environment. And then we've got the pH changes, we've got biocompatibility. We were talking earlier today about implants, and implants are made of titanium because that is a material that integrates well with the body and the body doesn't reject it. So with aesthetics, sometimes we have to give up the best material for things looking good. For example, earlier today I talked about gold crowns, and gold, the old-fashioned gold colored gold crowns, having very good wear properties for wearing with enamel, wears the most like enamel. But we might not want a gold tooth on our front tooth if we had to have a crown on a front tooth. Most of us wouldn't anyway. But we have to give up a little bit of the best properties to get a better looking restoration. So ceramic ware is okay, but gold is better, but we're going to give that up for a better looking tooth, crown in the front, on a front tooth. So mutually, we've got to look at materials being in a harsh environment and a harsh environment being a little rough on the materials. Ortho appliances make biofilm removal difficult, and dentures can have yeast colonize, so we've got to think about the different products we're using in regards to the environment that they're placed within and the oral hygiene of the patient. Early on in history, amalgams were widely used and they were accepted. Porcelain was used for inlays and crowns, but remember I talked about in class how the porcelain technology has gotten a lot better. Porcelain used to be very brittle and it would shear off easily. In the 1900s, we started using cast metals. We started using gold, which is a great restoration, wears a lot like enamel. We started using cobalt chromium for partial denture framework. We talked about how there's a little bit of nickel within some of the semi-precious metals, and how 15% of the population have nickel allergies or sensitivities. So sometimes when you see a restoration that has the tissues kind of angry around that restoration, it could be because there's a sensitivity to nickel. I talked about titanium being a very good restoration or a restorative metal for implants because it's biocompatible and it integrates well within the body for implants. We've got different cast metals that we're going to further talk about that we use in crowns, bridges, and dentures. And then we've got plastics and composites that came around in the 1900s. So fast forward to the 2000s, which we're still there now, there's a lot of new ceramic and porcelain technology. It used to be that the porcelain crowns that they made for the posterior weren't great because there was such compressive forces that the porcelain, which is brittle to begin with, would fracture. They had the semi-precious, and we talked about in class how you'd have the metal substructure underneath, and that was what gave the crown strength. And then you would have porcelain that was fused around that crown to give it an aesthetically appealing, look. So instead of a gold crown, you'd have a porcelain fused to metal just so it looked like the rest of your teeth. But if you didn't make that porcelain thick enough, the dentists, when they go in and shape for a crown, they shape all the way around and on top, and they make enough room for the porcelain and the metal so that when you have the opposing teeth biting against it, there's enough room for all of that. If the porcelain was too thin and the patient bit on something hard, sometimes that porcelain would fracture off because it's brittle. And then you would have the metal underneath that was showing. A lot of the times you could still leave it because functionally it was still covering the crown, but it just didn't look as good. And that's the original reason why you put the porcelain or used a porcelain fused to metal crown in the first place. So the porcelain technology has gotten lots better, particularly for posterior teeth. Anterior has gotten a lot better too. It's a lot more translucent and it looks a lot more like a natural tooth versus, kind of like a chiclet or you guys probably don't even know what chiclets are, the gum. But anyway, looks, it was very radio opaque versus translucent. So they've gotten lots better with the porcelain technology recently. So um, you'll see a lot more porcelain crowns in the future. The ADA sets the dental standards for drugs, dental drugs, materials, instruments, and equipment. Um, ADA seal of acceptance is a positive rating. It's given for a period of 3 years and you have to reapply. Even the advertising that you do for a product, so like Crest advertising is evaluated by the ADA as well. This is a voluntary seal of acceptance and it can be FDA approved and not ADA, but when it's both, people tend to view it as more credible, the products as more credible. So under the US FDA and Medical Device Amendment of 1976, the FDA has the authority to assure safety to all medical devices. So dental materials are considered devices, and there's 3 categories. So class 1 is the least regulated, just need a good manufacturing process. Prophy paste or toothbrushes fall under this category. Class 2 is approval from FDA when shown to be equivalent to products currently in use. So some items are grandfathered in like amalgam and composite, but pulp testers fall under this category and cabotrons fall under this category. Class 3 is the most regulated, and this requires pre-market approval and clinical data has to be submitted. So bone graft materials. And if you look at the different, like it goes from toothbrushes to bone graft, something they're putting in and hoping that your body accepts as a bone graft. So of course it would be the most regulated. Which of the following would be an FDA Class 2 regulated device? And that would be pulp tester. Pulp tester falls under category 2. Which of the following would be an FDA Class 2 regulated device? Ultrasonic scaler. So classification of dental materials can be by use. We have talked a little bit about the undercuts where amalgam fillings mechanically fit into a preparation because of the undercuts and because of the shape that the dentist will prepare it. There are some bonding agents, so it could be chemically and mechanically held, but typically mechanically held. We've got composites and some cements that adhere the product to another. So composites work by adhesion to the tooth surface. And we talked about when we have inlays or crowns, that we have no undercuts so we could get the crown on and off or the inlay in and out. Crowns completely cover the tooth surface that's remaining, and we would do a crown when a tooth is over half filling. We have a certain shape that the crown should be. If a crown is too big, it could go into the biological space and cause some periodontal problems. We've got bridges, which are considered permanent partials or fixed permanent partials, something like that. Those replace lost teeth or a lost tooth. We've got a complete denture, which would replace all of the teeth, so that would be for an edentulous person. We have a partial, removable partial denture, or a fixed partial denture, which is a bridge. But removable partial dentures are made usually with a metal framework that is cobalt chromium, and then some of them have just some plastic, almost some rubbery plastic, which is Valplast. We'll talk about those more when we get to that section of dental materials. We've already started talking about impressions and casts and models. So impressions are going to give us a negative reproduction of the patient mouth, and then when we pour it up in stone, we're going to have a positive reproduction. If we're using that positive reproduction to make something, that's known as a cast. And if we're using it for treatment presentation, that would be used for a model. Or if we are using it as an opposing model when we're doing a crown. If we have one single tooth, it's a die or dies if we're doing a bridge. And so that's the model that I showed you in class. We have different cements that are going to be for luting or cementation. That's been a board question in the past. What, in regards to luting, luting means cementing. There's been questions about bases and liners, so we'll talk a little bit about those. We started to talk about temporary materials, temporary crowns or temporary restorations. Some of those involve using ZOE, which is zinc oxide eugenol, which has the sedative effect. We've got preventative materials that we're talking about and we're learning about and we're doing in labs. So sealants, mouth guards, fluoride trays. We've got different polishing materials we're going to talk about. Even discs and kind of sandpaper strips for polishing around composites. And then we're going to talk more about implants, how to clean around them, and what they're made of, what the different components are, because that's stuff you're going to have to talk to patients about. And then we've got specialty behind my little face down here. There are specialty items and specialty materials, and that has to do with orthodontics and gutta percha for root canals, that kind of thing. Classification of dental materials can be by location of fabrication. So is it going directly into the cavity preparation like an amalgam, composite, or glass ionomer cement would be? Or is it being made somewhere else and then being put in the mouth? So direct is being placed directly in the cavity preparation. The dentist is placing amalgam in that prep. They're placing composite in that prep. They're placing glass ionomer in a class 5 area of demineralization that has progressed to a cavity, and they're placing them directly. They're having a metal crown, an inlay, a ceramic crown, or a plastic type restorative material made somewhere else, like made at the dental lab, and then it is being cemented into the preparation. So it's made somewhere else versus being directly placed at chairside. Indirect is it's made somewhere else and then we're placing it after it comes back from a lab. Different dental materials are classified by longevity of use. So we have permanent restorations, which are long-term restorations. I've seen crown and bridge last in their 50 years, and I've seen them be very short-term. Remember how we did that little circle? Every single thing has to be done properly along the way. We have to get a good preparation by the dentist to start out. Then we've got to get a good impression. We've got to get a good pour up. Then we've got to have a good lab that makes a good restorative item, so crown, bridge, denture, whatever, that can then be placed with the patient. So longevity depends on many things. The insurance company says that a permanent crown or bridge should last at least 5 years. So I guess 5 years is long term. Other restorations are temporary. They're intended to only be in there a couple weeks to a couple months. maybe while we're covering the tooth up for protection while we're waiting for the permanent crown to be made at the lab. And then we've got interim restorations. Those are long-term temporaries. So apparently my crown that's been in with temporary cement for 12 years, long-term temporary. If we have a child that has many large carious lesions and we're putting a temporary filling material in there like IRM, maybe they're 10 years old and we're trying to get them to 11 and a half when that tooth comes out. And we're trying to keep that tooth in there for function and for keeping the space open for the permanent tooth. If we have a patient who has had a fracture of a front tooth, or we have a patient where maybe they're missing 7 and 10 congenitally and we're trying to keep a space open for ortho, we are doing temporary, long-term temporary restorations at that point. We would not do a permanent crown on a patient until they were 16, 17, 18 years old, until it was completely erupted and the root was formed and we're not going to get any more movement. A child might need a temporary restoration while we're waiting until the pulp gets a little smaller. So lots of different reasons for interim restorations, but there's permanent, temporary, and interim restorations. So you've got to know, and this is a reminder for the GB Black's classifications, Class 1 being pits and fissures, Class 2 being posterior 2 or more surfaces, including a proximal surface, so a DO, MO, MOD. Class 3 is an anterior that's not including the incisal edge, so MF, DF, DL, ML. Class 4 is an anterior including this incisal edge, so MFI, something like that. Class 5 is the gingival third. It's usually on the buccal, but it can be on the lingual. And then Class 6 is that weird cusp tip. So that's Class 6, and you need to know those. Remember in class I was telling you that this is one of the things that you got to know, along with like the blood pressure guidelines, the staging and grading, the ASAs, like those you just got to know inside and out. So this is another one to add to the list. All right, in the U.S. standard for dental materials are developed and administered by which of the following? The ADA. An amalgam restoration located on the gingival third of number 3 is which classification? We know that's a Class 5. The walls of an amalgam preparation diverge while the walls of an inlay converge. True or false? Now, if we're thinking about the walls diverging, that means going out. And we know amalgams are mechanically held in, so that is false. It would be the opposite. Amalgams converge, inlays diverge. Which of the following is an indirect restorative material? Something that is made elsewhere. So amalgam's put in on the spot, glass ionomer on the spot, ceramic is the one that we are sending it to a lab to be made, composites on the spot. And then we have two types of restoration. So intracoronal, within the crown of the tooth, and extracoronal, and this would be more like crown and bridge in cases of more extensive damage. So crown completely covers the tooth all the way around and on top. And then we've got direct, so amalgam composite and cements like GI that are used as a filling material, or indirect when they're made somewhere else and then placed on the tooth. Endodontic treatment or root canal treatment is one of the specialty areas of dental materials. We're using a rubbery plastic material called gutta percha, which fills the canals. It's put in with a root canal sealer. It is usually further restored with an extracoronal restoration like a crown. Once a tooth has a root canal, it becomes very brittle because the blood supply is cut off. So a crown is usually the restoration of choice for a tooth that's had a root canal. A lot of the times the root canal is because there's been a very large filling, recurrent decay. Decay has gotten to the nerve of the tooth, and the only options are extraction or root canal treatment. So it's a very compromised tooth anyways as far as structure. Sometimes it's because a tooth got knocked, so it could potentially be an intracoronal restoration, so a small lingual pit composite filling that just goes into the access hole for an anterior root canal. If there is not a lot of tooth structure remaining, then a post and buildup need to be done, and that would give the tooth some substructure to be able to build a crown on. And you should be able to recognize those um, on an x-ray or radiograph as far as where there's a post, where there's root canal treatment that's successful. You should be monitoring the apex of that tooth to make sure that the infection is gone. And for tooth loss, a partial will replace several teeth. So if you had teeth missing on both sides of an arch, a partial could go in and replace a few teeth at once. Remember, I told you that a bridge is sometimes referred to as a fixed partial versus a RPD, a removable partial denture. A bridge is an extracorneal restoration, which has abutment teeth and then a pontic in the middle where the missing tooth is. That's indirect because it's made somewhere else and then it's delivered and cemented into the patient mouth. I showed you a Maryland bridge, which is like a little wing on the back. Typically that is used for number 7 and 10, congenitally missing. They have a tooth that goes into place and it's got a little wing that's cemented on the back of the teeth on either side. For that one, a lot of dentists have kind of stopped doing them, or they do them very rarely because they come out a lot. You bite on something just right and there's too much stress on those two teeth that are either, on either side, and they come out. And then sometimes they come out and people swallow them. Implants are another way to replace any lost teeth. Titanium-based alloy, which is integrated into the bone, and then a tooth or a crown is built on top of that. Implants are pricey, so probably $4,500 to $5,000 for each one. So sometimes the cost is prohibitive, and a removable partial denture will replace all the teeth at once on both sides of the same arch. We would do a removable partial to replace multiple teeth in multiple locations. If there's not a distal abutment available, sometimes they'll do a cantilever bridge, but they can't really do that in a molar situation. The cobalt chromium metal that is used for the partial framework displaces stress and it spreads the stress of the biting forces around. There's usually stops or rests on the abutment teeth, and when there's a partial that goes on both sides, and I'm thinking specifically lower, which is why I pointed to the lower, it distributes the occlusal forces evenly across the rest of the teeth. The one thing that people don't like about removable partial dentures is the clasps, because you can kind of see the clasp. Typically they might be on a premolar or even a canine, and you've got a metal clasp kind of coming across the bottom of that tooth, and you can see that. Sometimes they can fit it a little bit differently, where maybe we can get the clasp a little bit more hidden, but the clasps are seeing the clasps are the biggest probably con to a partial denture, removable partial. And if you have an edentulous patient, then you would do a complete denture. Anytime that you can keep any teeth in there, it preserves the ridge and keeps the ridge higher. If you have somebody who's very young and they're losing teeth at a young age, if they wear this denture for 20, 30, 40 years, their ridge when they're in their 60s, 70s is going to be almost non-existent, particularly on the bottom. A lot of people do well with a maxillary denture and that fits well, but a lower full denture is one of the hardest things for people to get used to and to wear and for it to be functional. So anytime you can keep teeth and preserve a ridge and maybe do a complete upper and a lower partial, that should be something that's a goal. We want to provide optimum function and support. So we've really got to weigh out the options of, which teeth can we keep, which will be successful long term versus which ones need to go. And patients are all like, pull them all, it'll be easier. And it's really not easier. You're just trading one problem for another. That is the end of part 1. This properties of dental materials is going to be part 2 since this video is starting to get a little bit longer.